A link to what's recording now, but I think there's going to be a lag. The goal was to try to do it to where there wouldn't be a lag so you guys could see what I was posting on my screen as I was, but I have a feeling there's going to be a lag because there's been a lag every single time I've tried to post it. But later on, if you're like looking at this after the fact, I'll have like my screen recorded, so I'll be pointing at things on the actual PowerPoint slide. So hold on. Today's 25th. It got really quiet. Alright. This is still gonna say Monday review. I'll fix it later. Cool. So if everyone wants to pull up like the PowerPoint, we'll go through it together. I threw in the slides from yesterday. I also threw in more pictures, just because I don't know, to keep things interesting. So I did put in the slides from yesterday, but we're not going to go over those again. I did record what I did yesterday, so if you weren't there for that, but you still want to get like a metabolism recap, like you're welcome to come ask me afterwards, and I'll talk you through whatever. But I don't think it's like the best use of everyone's time to just say everything I said last night. I think it's recorded, and the quality, like my audio is fine. So if you have questions, let me know. Otherwise, I'll kind of just skip over those slides when we get to them. So further ado, so first slide. Also, some of these pictures came from one of my friends found like an article today. It was like anatomy Snapchats or something, and I think they're like amazing. So enjoy them as we go along. But yeah, so starting off with like some of the DNA and RNA stuff. Again, like this is stuff I still feel like I have problems with. Like I was very surprised to get like more of these questions come up in like my practice recently. Again, like being recorded, but just knowing like I'm going to try to emphasize things to you that I think are important and that people that will pull out questions for the BSCE things they might like. So for DNA polymerase, keep in mind like which goes where. Keep in mind that like a 3 does the 5 to 3 prime and then 3 to 5 prime proofreading. Also keep in mind just like if they give you like a strand of DNA and they say like this is what it is 5 prime to 3 prime and they ask you like what is the complementary strand, you have to do like the 5 prime to 3 prime so you match up the ends. Like even like that really basic stuff can still come back for like even the step. Even though that was something that was maybe undergrad level, that still can come back. That might be some of the stuff they touch on with this nucleic acid stuff. One of the things I've seen multiple questions about in like UWorld and like I don't like in class and stuff recently is like the telomeres, which I think is kind of random, but I guess they like asking about them, so just mention them here. So these are for eukaryotic DNA, so they're adding extra stuff to the 3' end. And essentially the justification with that is that as you go and you do duplication and then you're moving the DNA strand around, you're not like losing parts of this DNA strand, so it's kind of like a protective feature almost. So telomeres are that extra elongated 3' end, and the telomerase enzyme is specific for eukaryotes. So you won't see that anywhere else, so essentially it's just elongating, it's like a protective feature. Histones is something that I think will come back over and over again. So this is like first week biochem, I think. So knowing like methylation means that it's going to inactivate transcription. Like just that general idea that methylation inactivates transcription is huge because a lot of like even the genetic conditions you talk about, like the imprinting, we're methylating a strand of DNA. So now there's not transcription occurring, and what happens as a result of that? So know that methylation, there's no transcription, no acetylation will activate transcription, so acetylate activates transcription, and that it's making more euchromatin. So this is, again, very, very like nitpicky, like DNA level biochem, but euchromatin is the one that is transcriptionally active. You also have heterochromatin, which would be the comparison, so that's transcriptionally inactive. The way they could tie that in is say you have a patient with like Klinefelter syndrome. They have that extra X chromosome that's now a bar body. So a bar body has heterochromatin because it's transcriptionally inactive. So make that connection. Bar bodies have heterochromatin. Histones are responsible for wrapping around having DNA wrap around them to help organize it. You have the different histone units. I don't think they would ask anything that in depth, but if they do, know that the H1 subunit of histones are essentially linking the strands together. They're not a part of that like 8 block of histone that wraps around the DNA or has DNA wrap around it. It's more like along the string. string. So like the beads on the string appearance is from the H1s being a linker protein to link histones together. Histones in themselves are very rich in lysine and arginine. So these are positive amino acids, which makes sense because nucleic acid DNA is negatively charged. So having positive amino acids in a histone means that the DNA can wrap around well and it'll hold on to it. And then they could be acetylated or methylated to kind of do what they need to do. So next slide. Again, like the lysine and arginine, that's an important thing to keep in mind because they're positive amino acids. And sometimes, like if they specify like where this amino acid comes into play, like you need to keep track of it. Like we talked about last night, like heme synthesis, you need to keep in mind that glycine is the amino acid that's filtering in to form heme molecules. Because they can ask like specific, like what amino acid does this thing. So amino acids and histones are lysine and arginine. Amino acid that goes into heme synthesis is glycine. Also keep in mind with heme synthesis that it's glycine and succinyl-CoA that filter in. And they are like the beginning of forming your heme molecules, your porphyrin molecules. So next slide is just like random things, because I hadn't seen them in a while until recently. So if you see them, just a reminder of what they are. So you have the TATA, like the binding box. So this is in the promoter region, so at the beginning of a DNA strand, where everything is essentially attaching to like have a transcription and the processes occur. So the TATA binding box is rich in the A and the T. So this is where the transcription factors and RNA polymerase can bind. Besides that, like knowing it's in the promoter region, knowing it exists, and knowing that if something attaches to it, it allows for transcription to occur. Pretty much all you need to know. And then I like have a hard time keeping like transcription and translation straight sometimes. So keep in mind that transcription you're forming that mRNA, and that translation you're making like the protein. So transcription, after you have transcription occur, you have modifications that are specific at that time. So you have the 5' cap. So you add on the 7-methylguanosine, and this is a protective feature, kind of just like holds the strand in one piece as it moves forward and goes through different processes. You have 3' polyadenylation, so all the A's on the end of the 3' end. This is mainly important in like moving the mRNA from the nuclease, or from the nucleus, it should say, and it protects against the exonuclease function. You also have splicing that can occur. I think the most high yield is the alternative splicing. One of the ways they could get at this concept is they could give you a gel electrophoresis, which is essentially separating out like proteins based on like what they're doing. And they could say like, oh, we took the same gene from different tissues and it's all spliced out. And you see like, oh, in the heart it has like 1 million bands, and in the lungs it has like only a few bands. Well, if it's the same gene and it has like kind of different proteins that are expressed in different places, that would be an example of alternative splicing, where you're essentially packaging up the same gene differently to achieve different functions at different sites. So they like the idea of alternative splicing, so keep that in mind as you're going forward. And then post-translational, so essentially you have the protein that's been formed. So what you can do after that is you can kind of trim away some of the amino acids during proteolysis to make the protein more mature. You also have all the things like glycosylation, phosphorylation. So keep in mind you have like the O-linked and the N-linked glycosylation. So O-linked, you're talking about serine and threonine residues. And then N-linked glycosylation is dealing with arginine. I always forget or asparagine. They always look the same to me. So N-linked is asparagine, O-linked is serine and threonine. So you also have gamma carboxylation, and where this comes into play is the coagulation cascade. So keep in mind that vitamin K achieves gamma carboxylation of important coagulation factors, so factors 2, 7, 9, and 10. So if I have a vitamin K deficiency, that would lead to bleeding problems, so gamma carboxylation, which is a post-translational processing step. You have ubiquination, which you need to know in terms of it occurs at the proteasome, so it'll essentially destroy anything that looks kind of funny to the body. So just keeping itself in track, only producing things it really needs to produce, and if there's mistakes anywhere, it has processes in place to destroy things that are misshapen and then make them again. You have hydroxylation, methylation, acetylation, so all of those occur after translation, so during the protein. All right. So next picture is just a picture of replication. This is eukaryotic replication because you're dealing with the different polymerases that are alpha, delta, and then there's a beta polymerase too, but it's not really as important. So the alpha polymerase is the one that's going along the lagging strand. So you have the Okazaki fragments that are formed, so there's gaps in between them. And what's unique to eukaryotic DNA in that sense is that you have a DNA ligase that comes in afterwards to fill in the spaces. So ligase functions in filling in those fragmented spaces, forming phosphodiester bonds to keep everything as one solid strand. And then the leading strand, you have the delta that's making the leading strand just fine. Both of these occur like the 5' to 3' direction. Helicase helps in unwinding. Single-stranded binding proteins are essentially like once you unwind the DNA, they hold them in place. So then you can do replication, do transcription, whatever you need to do without the DNA recoiling back on itself. And then topoisomerase also helps introduce coils to unwind the DNA in like another sense. Alright, so purines and pyrimidines. This also, the picture came from a BuzzFeed article. It was like me as a doctor. And I don't know, it made me laugh because I feel like, especially when you get into like interacting with your colleagues more in like patient settings, like you'd be surprised what some people will say. But everyone's going to make it and be fine doctors one day. It's just the process of getting there. So purines and pyrimidines, we talked about last night, kind of important enzymes to know. So at the bottom you see like the pyrimidine rate-limiting enzyme step is CPS2. Don't get this confused with CPS1. So CPS1, the carbamoyl phosphate synthetase, I think it is, 1 belongs to the urea cycle. So that's in like the liver mitochondria, and this is talking about CPS2 that was going to deal with pyrimidine synthesis, so making the A's and T's. Yeah. No, T's and C's. And then A and G are purines. Little stuff like that, I swear, I feel like I should know it like in and out, but sometimes it makes me second guess myself. Purine de novo synthesis, that PRPP aminotransferase is the enzyme you need to care about. But also really, really important with purine salvage pathway, where you're essentially you don't need to make more purines, you can just kind of recycle them. So the disorder that comes into play here is the Lesch-Nyhan syndrome. So in the clinical stem, you'll see a young kid that's like constantly like biting at himself. So it's like the self-mutilation is like the extreme term they use for it, where you have a deficiency in the HGPRT enzyme that leads to buildup of metabolites that kind of make them super itchy. So that's why they get all the lip biting and things like that. They can get like gout. Orotic aciduria, it's worth mentioning here because it's something people will get confused with, like a urea cycle defect. So you know in the urea cycle you have the OTC enzyme that's making like citrulline, I think, from ornithine. So if that enzyme is affected, you also get orotic aciduria. So you can get them in either condition, but they're obviously coming from very different processes. So in this case, this is coming from the purine process. So you have a defect in UMP synthase. So if you don't have that, orotic acid builds up. Where similarly in the OTC deficiency in the liver mitochondria in the urea cycle, you also get a buildup of orotic acid. But in that case too, you would also see the high ammonia, which will help you differentiate it. Knowing gout is from the purine salvage pathway, also useful. I know it says xanthine oxidase, like if that's defective, or if it's like overworking or something, you can produce too much uric acid. That'll build up and form gout. Like you'll see someone that comes in with toe pain, you would expect to see maybe gout. And knowing gout, that's one of those conditions where you can see like crystals in the urine. So there's a couple things that you need to keep track of for that. So gout, you see the uric acid crystals. You have ethylene glycol poisoning, that's antifreeze poisoning, which was like something that showed up a ton for us in recent times. And that's calcium oxalate crystals. And you also have the other one you need to kind of lump in with the crystals in the urine is cystinuria, where you'll see hexagonal crystals. So those are the most common like cause of like stones in kids, where they have a deficiency in like absorbing the cholamino acids, so like cysteine, I think ornithine, arginine, and lysine. It's kind of a random condition, but cystinuria, you'd also see the staghorn stones in the urinary tract. So next slide is hemoglobin. So this is something that pops up in biochem, and you would have seen it in genetics. So this is really just to remind you that these disorders exist. So you have alpha thalassemias and beta thalassemias. So you have these genes that encode for parts of different hemoglobins. So knowing like the composition of like hemoglobin A, A2, and like kind of what goes into it will help you make sense of like why if these subunits are not there, you get extreme problems. So the most extreme problem you can get with alpha thalassemia is the HB-BART. So that's kind of that second one there. So essentially, this is when two parents that are cis carriers. So essentially, if you are looking at the strand of DNA, you have the two top alpha genes and you have two the bottom. So essentially, one parent has the top ones knocked out and the second parent has the bottom ones knocked out. So when they reproduce, they have a kid that has everything knocked out. So this is two cis parents that will reproduce and have a kid that has no functional units. So they get the gamma-4 tetramers. This is not compatible with life, so they get the hydrops fetalis. Kind of one step below that is HBH, where you have the one cis and one trans. and when they reproduce, they have a kid with one functional unit. So this is actually compatible with life. They have just the one. They'll still get the beta-4 tetramers, but they can live into adulthood. Beta thalassemias, you have like major and minor. There's also intermedia, but that's, I feel like, not as talked about, so I'm just not including it here. So for these, like, I think the most important thing for beta thalassemia is to know what it looks like on gel electrophoresis. So if they wanted to be like really nitpicky, they could give you a gel electrophoresis like this. So this is pulled from like my genetics lecture, which you probably have like similar pictures too. So it also includes on here the sickle cell trait and sickle cell disease. So know with sickle cell, actually the full-blown sickle cell anemia, you have the glutamine mutation, and that sickle cell trait, you have glutamate for lysine, sorry. With sickle cell trait, the important thing to know is that it's the HBC. So if you look at the gel electrophoresis, they don't show it great. I think I also wrote it wrong in my notes, so ignore my little scratch from biochem. But with HBC, since you're changing it for a positive amino acid, it's going to migrate even more slowly. So if you looked at like a band of it together, and I'll try to put in a better picture to show that, it's going to migrate the slowest because it's going to stay more towards the negative end of the gel. And then HBS will migrate a little bit farther, and then with the beta thalassemias, you're kind of knowing, is the HbA absent, or is it there? Is HbA2 increased? Is HbF increased? Keep in mind with HbF, the reason that has such a high oxygen binding affinity is because it doesn't interact with 2,3-BPG as strongly, which means that 2,3-BPG, when it does bind, it puts the hemoglobin molecule in a taut state, so it's going to release oxygen. So if it doesn't interact with it as strongly, it'll have a higher oxygen binding affinity over time, because it can hold on to the oxygen better because it's not interacting with 2,3-BPG. So the next picture is just something you should know. It's something that comes up in every class. We literally just talked about it upstairs with term 1, even in their respiratory lecture. Knowing what can shift a hemoglobin graph, I swear it will come back over and over and over again. Make sure you have this graph down. Keep in mind when you're shifting to the right, you're reducing affinity, so you're unloading oxygen to tissues, which makes sense when you're talking about things like exercise, which isn't in this picture, but know that exercise will shift it to the right, because you want to put all that oxygen out into the tissues so they can use them, because they're having high consumption during times of exercise. All right, so next slide. Eicosanoids. Pulled this up because it's probably something you haven't seen in a while. So this is the pathway where the arachidonic acid comes from the lipid membrane. It's cleaved by phospholipase A2. Keep in mind that phospholipase A2 can be blocked by cortisol, so corticoids would inhibit that step. And then it can go on to form prostaglandins through the cyclooxygenase enzyme. So 1 is constitutive, so it's always expressed, and 2 is non-constitutive. So it's really going to be expressed in times of inflammation, where you need even more prostaglandins than usual. It can also make leukotrienes through 5-lipoxygenase. So leukotrienes, you're thinking things more like asthma, where it's going to constrict the airways. The really, really important ones to know are PGI2, which is called prostacyclin, and TXA2, so thromboxane A2. So they have different effects from each other. So prostacyclin is going to inhibit platelet aggregation and it cause vasodilation, whereas TXA2 is going to cause platelet aggregation and vasoconstriction. All right, so bleeding disorders. Ones that are really important, hemophilia A and B, I'm sure everyone remembers those just fine, but von Willebrand deficiency is one that's actually pretty high yield. So keep in mind that this is dealing with primary hemostasis. So this isn't the coagulation cascade, it's forming that platelet plugged. So if you don't have von Willebrand factor, you can't do platelet adhesion. So what you'd see on the actual panel when you measure the different lab tests is increased bleeding time. So bleeding time refers to like platelet plug formation. So with hemophilia A and B, you wouldn't have increased bleeding time. You'd have increased APTT. So APTT is measuring that intrinsic pathway, and PT is measuring extrinsic pathway. So PT, the only factor that's really unique to extrinsic only is factor 7. I always have trouble remembering exactly the order of a coagulation cascade, but usually that's not the question. So keep in mind with extrinsic, factor 7 is the only one that's like unique to that pathway. So if they gave you a situation where only that factor is affected, you'd see the PT is increased, but APTT is pretty much everything else. So hemophilia A and B, you would see the APTT increase, and then with von Willebrand deficiency, you'd see bleeding time increase, but you'd also see the APTT increase because von Willebrand factor plays a huge role in stabilizing factor 8. So if you lose that, you kind of knock out both factors essentially. And then the histotion is that it's stored in the Weeble Palade bodies, which I just love that term. It could pop up for you guys. It popped up for us earlier this term, and I completely forgot about it. But it is mentioned in first aid. It's mentioned in different websites too. So know that that's where it's coming from. All right. So next ones are secondary messenger systems. This is just a like shout out. You don't need to necessarily know like the super detailed stuff, but like one of the things that has showed up for us is it was like a question asking about how does the second messenger system work, or like which of the following correctly describes it when it's active. So know that the system is essentially active when the alpha subunit, so there's like alpha and beta gamma subunits, when the alpha subunit binds to GTP, the system is active. So that's when activation like fully starts. That's when you can say the system is going. So when the alpha subunit binds to GTP, it's in its active form. No cyclic AMP is working to make protein kinase A. It's used in systems like with epinephrine, like it's mentioned in this picture, but also keep in mind with glucagon, because glucagon is a phosphorylator. So glucagon is going to activate cyclic AMP, so it'll activate protein kinase A, and you can make a lot of inferences about what happens with the gluconeogenesis enzymes as a result of that. The picture next to it is the cyclic GMP pathway. So biggest thing to know about this is that nitric oxide is formed, which has roles in vasodilating, obviously. A lot of times they talk about nitric oxide in the form of like patients with heart failure, they'll give them nitrates, or they could talk about like men with erectile dysfunction. They can give them drugs essentially that are going to inhibit cyclic GMP from like breaking down nitric oxide, so it stays in the system for longer and you can vasodilate, which is helpful in that condition. On the next slide, it shows the IP3 DAG pathway. Again, I don't think you need to know all the steps. This is just to include to you to make sure you know kind of what components go into this pathway. So no, this is one is dealing with the phospholipase C. You have protein kinase C. Again, like I mentioned yesterday, IP3 DAG, I can remember that it makes calcium. So a lot of the second messengers that are trying to, or hormones rather, that are trying to constrict things are going to activate through this pathway because they need calcium to constrict the muscles. All right, so next one, we're skipping through some of these. If you'll go, there's a slide on nutrient deficiencies that has a picture of a girl being super creepy. This was just to mention a couple things that I didn't talk about yesterday. So phenylketonuria. No, there's different kinds of phenylketonuria. Type 1 would be when the phenylene hydroxylase is deficient. You could also have PKU2, or the tetrahydrobiopterin, like the enzyme to essentially regenerate that is defective, which is even worse because now you don't have tetrahydrobiopterin, so all the pathways that use that, pretty much like all the ones with hydroxylases, are now out too. So PKU2 is worse. I haven't seen it pop up in recent times, but like, again, they mention it so much in like lectures and stuff, I wouldn't put it past it to show up eventually. Maple syrup urine disease, no, this is dealing with branched chain amino acids, so like things like valine. And then tryptophan, if you see a presentation of a kid that has like a skin rash or like irritation of the skin, he has like GI problems, think of something maybe like Hartnups, where you have problems with tryptophan absorption. So keep in mind tryptophan is used to make niacin. So essentially if you have a deficiency of tryptophan, you'd have a deficiency in making niacin, which you should think NAD, which is involved like everywhere. So it's like a big deal, and the pellagra is that combination of like the diarrhea, dermatitis, what is the third D? Dementia. And they sometimes include death. So if you see like all of those factors together, think of something that involves tryptophan that can cause pellagra. All right. And then we're skipping until, all right, the genetics section. So this is one that I wanted to review more to talk to you guys, but the biggest thing I can emphasize is all these terms are what throw me off a lot of times. So they'll give you like a condition where they'll say like maybe a mom has 2 kids and both kids have the same gene, but one of the kids has like a very severe presentation and the other one is like almost fine completely. So like what is the term for like how this is happening? So like that would be like variable expressivity. So they do things like that where they'll try to get you on like what is this term actually saying, or incomplete penetrance. So that's a saying they have the mutant genotype but they don't express at all. So the example columns that these are from first aid are good to know. because they will try to ask you about terminology and do you know what this term means. Even if you know what the disease is and know like everything else about the disease, if you don't know like kind of what the term is, you're not going to get the question. So they really like variable expressivity. Anticipation is an easy one to remember because it's deals with trinucleotide repeats. So you think about things like Huntington's, where they're getting more repeats, they're going to have a more severe presentation earlier onset. Linkage disequilibrium is kind of a random one, but if they gave you some presentation where they're saying like, oh, we did a study about these two genes and how they play a role in disease, and we see that they're always pretty much at the same levels and across like different populations, that might be something like linkage disequilibrium. So this is saying that two alleles are pretty much present together a lot of the time, so they might be on the same gene. So look over these terms on the next slide too. There's just more terms. So mosaicism, one of the things to keep straight is there's somatic and germline, so gonadal. So keep in mind with germline mosaicism, this is saying the actual like germinal cells are what it's affected. So the patient that has germline mosaicism doesn't have the problem. It's their kids that are going to have the problem. So you can differentiate that from somatic mosaicism. Mosaicism just means that some cells are affected and some aren't. So this would be like a less severe disease presentation. So something like Turner syndrome usually is from meiotic non-disjunction, but it could also be from mosaicism. If it was from mosaicism, that would mean that not all the cells in the body only have 45X. Only some of them do. So it's less severe. Keep in mind that with germline mosaicism, that person doesn't have the disease themselves. It's their kids that will get it because it's from their germline. All right, so move on. So a couple unique disorders just to throw out to you. I know I mentioned this last night, but I don't know why they like Fragile X so much. So no FMR1 gene, hypermethylation. So you think methylate, it's inactivating transcription. And the presentation is always the macroorganism, large jaw, everted ears, and then they'd have mental problems as well. Huntington's, this was something that was super random in recent times, but it's on chromosome 4, the mutation. There's like a rule of quattros or something that my friend mentioned. Like, I had never heard of it. It was something like, it's like chorea, it's on chromosome 4, so like quattro, something like that. Really random, but no, it's on chromosome 4 if they try to get that with you guys too. And that the other two, the myotonic dystrophy and Friedreich ataxia, are also trinucleotide repeats. So link them together. The Credo shot, I forgot this existed, but a lot of times like an answer choice is like even on UWorld and stuff, they'll list like a 5' deletion as an answer, and I'm just like, I don't even know where that comes from. So keep in mind this is this random little disease, and what you're going to look for in that case is the cat-like cry, which is pretty much what they have to give you that to identify this disease. It's chromosome 5. And then imprinting is the Prader-Willi and Angelman. So this is just to say that usually from mom and dad, you can inherit the genes from like one parent, and they should always be silenced. So essentially, like with the Prader-Willi, I think it's that the DNA you're getting from the dad should always be quiet. So if for some reason you inherited the mom's gene was defective, so say I got a bad strand from the mom and dad's is just normal, but it's not ever supposed to be expressed, so it's not. So that gene is not being expressed anymore. Or you could get like inherit essentially 2 inactive strands from the dad, something like that. So keep in mind, imprinting has to do with like a normally set like inactive strand, but now the other strand is inactive as well. So you get like an actual pathology. All right. Testing. This is honestly just a slide to mention like they could ask you about what tests do. I don't think it'll be anything in depth. I know they went much more in depth with it with your genetics class. So the snowdrop mnemonic that helps you, because sometimes they'll give you like an example where they'll talk about like we're doing a study and we're trying to run a gel and do all this mRNA business, and like what kind of gel would we be running? So it'd be like a northern blot. So also keep in mind with ELISA, this is something that's detecting like antigen-antibody interactions. So if I have like an antigen and I'm trying to attach antibody to it, that's just an example of ELISA. They'll probably be very basic with how they're like asking like what these tests are. Keep in mind that the fluorescent in situ hybridization is really helpful for things like DeGorge syndrome, where you have the deletions, or even like translocations sometimes too can show up. I think mainly deletions though. So DeGorge, you have that 22q mutation where you have like deleted segments. So like DeGorge syndrome, keep in mind like the 3rd and 4th pulmonary pouches are affected, so they'd have things like hypocalcemia, they'd have an absent thymus, so they could have like a lot of immune problems, so come up in your immunology class. They'd have heart defects, all the catch-22 mnemonic will help you with that, but it should be pretty easy to pick out if it comes up. And then karyotyping would be something you use for trisomies. So karyotyping is where you're lining up like all the chromosome pairs. So if you have an extra one, that's where you would detect it very well. So keep in mind trisomy 13, that's the Patau syndrome, so you have the rocker bottom feet. 18 is Edwards, and then 21 is like Down syndrome, which is associated with so many things. You'll talk about it much more in pathology, but for your purposes right now, just know like to do that, you'd want to do karyotyping. All right. I love this picture too. This is from the same article, so enjoy. So cardio section, I really like this section, and I think it's very high yield. So I know you guys went through it really quick yesterday if you went to the big review, so we'll take like a little bit longer to talk about like some of the stuff because it's important. So the picture of the diagram of the heart is just to remind you of like where the different values are talking about, because I remember that was something that was a hard time for me. So keep in mind venous return is talking about the blood coming into the right side of the heart. And that cardiac output is talking about the units or the volume of blood per unit of time coming out of the left side of the heart. And then stroke volume is the actual volume. So if you look at like the next slide, we'll talk about embryo and then we'll talk about equations. So embryo, huge for the heart. Knowing all of these conditions, essentially right now what you need to know is the very detailed embryo presentation, and then later on you get to the path, you'll talk about like how this presents more. So the PDA, you should know that this is a continuous machine-like murmur. So if they give you a phonocardiogram that's essentially going like up and down like crazy, throughout diastole, throughout systole, you're looking at a PDA. Pratt and foramen ovale, this would be like the really nitpicky heart embryo, where you have the primum that's growing up and you have the secundum that goes down. And that normally during renal development, there should be that foramen ovale there, because you don't want really blood to go through the lungs when you're in utero, because the lungs aren't obviously breathing oxygen, so you kind of want to shunt it away. But if it's still present after birth, it's usually not a big problem, but just know like the little details essentially that those two didn't fuse. And that in utero, essentially the foramen ovale is formed because the septum secundum doesn't go all the way down. Tetralogy of Fallot, know the tetralogy of the four things: the pulmonary stenosis, VSD, right ventricular hypertrophy, and overriding aorta. Tetralogy of Fallot, truncus arteriosus, and the transposition are all due to failure of neural crest cells to migrate. And then that leads to different actual pathologies in themselves. So tetralogy of Fallot, you have the anterior superior displacement of the infundibular septum. I generally don't remember if like you had to know that for anatomy. You have to know it for path, but like I feel like it could have shown up in anatomy, so I'm just mentioning it here. Persistent truncus arteriosus, so you lack the aortico-pulmonary septum formation. Coarctation of the aorta, you see this with things like Turner syndrome, so where essentially like the blood isn't flowing out of the aorta very well because it's constricted at one point. So this is something that you'd see like on the chest x-ray, you see the notching of the ribs, the coarctation of the aorta, and then transposition of the great vessels is what it sounds like, so things are kind of flipped around. Is it because the aortico-pulmonary septum didn't spiral the way it was supposed to. But all of those are due to neural crest cell dysfunction. And then keep in mind that tetralogy, truncus, and transposition, the T's, are all right to left shunts. In case they're actually which way the shunt flow is going. If you see the T, think right to left, because usually shunts go left to right. Equations, so equations are, like, I want to tell you don't have to know them because I don't want to put that upon you, but you do need to know them. Especially, like, one of the things I kicked myself for is that I literally just taught Term 1 CardioPhys, and I could not remember what the MAP equation was on a practice question I was doing recently. So know what MAP is, because one of the things that they could ask you, like, second order, is that you know that MAP is equal to cardiac output times total peripheral resistance. So if I was given in a question stem someone's blood pressure, so systolic over diastolic, and I was given their cardiac output and asked to calculate total peripheral resistance, that's kind of a two-part process where you need to know how to calculate MAP. So if we give you like systolic over diastolic, 120 over 80, you need to know how to put those together, the 2/3, the 1/3, to make MAP. So this is in first aid. I know there might be like a little bit different versions of it in different places, but just really like know the best way to calculate MAP, because they will ask you at least like a couple cardiac calculation questions. The Fick principle, so the rate of oxygen consumption over the arteriovenous difference of oxygen content could be used to find cardiac output. And keep in mind that cardiac output appears in multiple equations, so essentially they could ask you to go across multiple equations to find different values. Pulse pressure was a concept to me that like I had trouble wrapping my head around for a while. Like, it's easy to remember that systolic minus diastolic, but what changes pulse pressure could be a question. And instead of trying to wrap your brain around like everything that can affect systolic and diastolic, just keep it basic. So pulse pressure will change with stroke volume and aortic compliance. So if I'm increasing stroke volume, I increase pulse pressure. If I decrease aortic compliance, which is saying that like now the aorta is stiff. So think about like people when they get older, essentially like all their arteries harden, and that can possibly like go back up into the aorta. So now it's like harder than it needs to be. So it's less compliant. Compliant meaning that change in volume over change in pressure. So it's not very receptive to stretching out anymore. So if I have a decreased compliance, that would also increase pulse pressure. So pulse pressure increases with stroke volume when stroke volume goes up, and will increase with decreased aortic compliance. So it's, the aorta is stiff now, pulse pressure will go up. So again, that's something you would see normally when you're aging. So that's like the physiological example of pulse pressure increasing, and one of the pathological examples they love is aortic regurgitation. So, or aortic insufficiency. So that's to say that like the aortic valve doesn't close all the way. So after you do systole and pump blood out of the left ventricle, blood goes back in. So it kind of flows back in, which means the next time the heart goes to pump, it has an increased preload now. So with aortic regurgitation, you increase preload, which increases stroke volume. So it's still the same concept. So stroke volume goes up, so pulse pressure goes up. So keep in mind with pulse pressure, what changes with stroke volume and how it changes with aortic compliance. It should be a pretty easy question. Like, don't overthink it more than that. I'm sure you guys probably didn't have the same problem I did with that, but just in case you did, like, try to keep it as simple as possible. All right. So next up, action potentials. Again, everything about the cardiac system is really important and high yield. So knowing at the SA node, it's different pretty much from where you see action potentials everywhere else, because they have this funny sodium channels where they don't even have a phase 1 and phase 2 anymore. So phase 4 is dominated by the funny channels, which are essentially like allowing sodium to move at all times. It's not really like set sodium gates. Like usually when you talk about like basic cell phase, you talk about like M gates and H gates, and they're open or closed. In this case, the funny sodium channels are like essentially always open, so there's like constant depolarization. But the rapid depolarization in the SA node is due to the L-type calcium channels. So don't get that mixed up, because in the SA node, depolarization is denoted by L-type calcium channels. In the AV node, it's denoted by sodium influx. So that's kind of what you normally see with all the other cells in your body, the sodium influx for the AV node, but the SA node is unique. So calcium dominates depolarization in the SA node. And then AV node, keep in mind you have this plateau period to phase 2. And that's because you have some calcium going in. That's kind of like offsetting the potassium going out. So it holds it as the refractory period for a while, which is a good thing because like at the AV node, like you normally have AV node delay, which if you remember from phys is like an important concept to say that like as soon as the AV node gets the impulse that it needs to contract, it doesn't want to do that right away because you want to have time for the atria to pump all the blood into the ventricle. Because if they contract at the same time, that would be ineffective. You want the atria to contract first, and then you want them to fill the ventricle and have the ventricle like wait for a second to get all the blood it can before it contracts and pushes the blood out. So AV node delay is an important concept to keep in track. SA node will set the pace, and then AV node kind of delays it a little bit, which allows time for filling to occur. So that's something you see on like an EKG. So that PR interval, so that's saying between like the atria contracting, so the P wave is like the atrial depolarization, and the QRS complex is ventricular depolarization. Just saying like atria contracting, then ventricles contracting. And the PR interval is the space in between them. So during that time, the PR interval is saying like I'm giving time for the atria to fill the ventricles before I pump the ventricles out. I don't think they'll go after EKGs for you guys. It's something that'll come back against term 5. Like, trust me, we just had it, and I think everyone forgot it since term 2. So the most I think they could ask you is like, what are the different waves talking about? But I wouldn't spend like a ton of time looking that over again in case you're like worrying about that. And also, disclaimer, like even doing this review, this is more just to kind of remind you of things that exist. I don't expect like anybody to go into that exam knowing every single part of everything we're talking about. This is just like kind of get a broad base, so you'll be fine during the exam, and then you'll fill in the gaps as you go along. Like, trust me, even if I took this exam on the things like I'm talking to you about, I wouldn't get like 100%, or anything like that. It's just kind of like casting a net for you to know what to expect. If you kind of know the basics, you're going to be fine. Like, most of the questions aren't that in-depth. They're going to be more first order, more easy for your purposes, so don't get too stressed out. And don't spend like all your time trying to learn this. Like, don't forget, term 2 is really important. So next slide is the pressure volume loop. Hopefully this is a little bit easier graph. So this is talking about changes in volume relative to changes in pressure. So keep in mind when the valves are opening, which valves are opening. So mitral valve closure, aortic valve opening, aortic valve closing. So this would be an example of the left ventricle. Obviously, they could make a pressure volume loop for the right ventricle if they wanted to. I feel like the graph is pretty self-explanatory, keeping in mind that like stroke volume is that space in between, and that if they ever asked you to calculate what the ejection fraction is, you should go all the way to the, if you look at the left graph on the left, you see that little notch on the bottom for end diastolic volume, and then you see a notch for end systolic volume. So the difference between those is stroke volume. So to calculate ejection fraction, you would see what the stroke volume is over what the end diastolic volume is. So essentially what part you pumped out relative to that total volume, the EDV that you filled with. So normally the ejection fraction is definitely like not 100%. I think it's usually like 50%. But if they ask you to calculate it, just keep in mind it's stroke volume over EDV. And you calculate stroke volume by the difference between end diastolic and end systolic. And then to the right, it shows like the changes that you can see with different variables that change. So preload. Biggest thing that you should remember for preload is that in heart failure, one of the first things that changes in heart failure is you have a decreased contractility, so now your heart's not pumping as well. So one of the ways your body goes to compensate is that it'll activate the RAS system to increase blood volume. So on the next slide we'll talk about or I don't know if it's the next slide or the slide after, the Guyton cross plots. So where I'm increasing preload. So in heart failure patients, they'll increase preload to kind of help with the fact they're not pumping as well anymore. So on the pressure volume loop, increased preload is that out to the side. Contractility is kind of an up and down, and then afterload, if you see in B, think of something like hypertension, where it's now pumping against a higher pressure, to where it's not going to be able to pump as efficiently anymore. So, alright, so next slide is talking about valvular disorders. Valvular disorders are huge, so this was like notes from like one of my DES that I so I pulled these pictures from the CardioPhys website. It's like cbsphysiology.com or something like that, but I really liked their pictures. I don't think you'll get like a Wigger's diagram per se on the BSCE too, but I wouldn't put it past them to show you kind of these pressure time graphs and ask you kind of what's going on. So for your purposes now, you should know kind of how to identify what the pathology is by looking at this picture. You should know how to describe what the sound is, like if it's an opening snap, like the actual word description of it. You should know what it looks like on a phonocardiogram, so like a crescendo, decrescendo, so it's getting bigger, then it's getting smaller. And then if it's a systolic or diastolic murmur. So I'm sure everyone's probably heard the Mr. Ass, Miss Ard mnemonic. I think that's like a lifesaver for the most part, because it just makes thinking so much easier. So just mitral regurg and aortic stenosis are systolic murmurs, and that mitral stenosis and aortic regurg are diastolic murmurs. So the Mr. Ass, Miss Ard, if you've never heard that before, like definitely talk to me after, because like that's a really important one to keep in mind. So stenoses, I think, are easiest to pick out when you're looking at a graph, because you'll see that you have that pressure gradient that forms. So it's either between like the mitral or the atria and the ventricles. If you're dealing with like mitral stenosis, so you're during diastole, when the atria go to fill the ventricle, they have to pump against the stenotic valve, so a pressure gradient forms. Or during aortic stenosis, you have to pump out against the stenotic aortic valve. So the left ventricle has to generate a ton of pressure to open that valve and pump out. For mitral regurg, what you should see, that tall V wave, that's just to say that at that point in the graph, that's when the systole is occurring. So the left ventricle is pumping out, and when the left ventricle is to pump out, some of that blood squirts back up into the right or the left atrium. So the tall V wave, that spike in left atrial pressure, is because some blood flows back because that valve's not closed all the way. And then the aortic regurg graph, it's a hard one if you're looking at it by itself, but what essentially you're trying to take is that compared to the normal graph, the pressure line, the y-axis is a little bit higher than it needs to be, because after the left ventricle goes to pump, during diastole, some of the blood will flow back. So the aortic pressure is a little bit higher than it usually is. Or the left ventricular pressure is higher than it usually is. Aortic regurg, again, is something they could use to talk about pulse pressure. So keep in mind that some blood flows back, so then on the next beat, it has an increased preload, so it would increase pulse pressure. Alright, guiding cross plots. So this is Erin's picture because she's great at drawing things, so this is essentially like all the ones you need to know. Basics that you should know is that you have a line that's the vascular function curve, so this is talking about blood vessels. So what could I do to change blood vessels? I could make them constricted or dilated, or I could put more volume in or less volume in. So keep in mind they'll shift with things like IV fluids will shift them out because you're increasing blood volume. They'll also shift with things that will change total peripheral resistance. So things like hypertension, or they could give drugs. I don't know. I don't think they'd go after like things you learn in ANS. I generally don't remember how important what things were for the BSCE 1, but that's something they'll more go after for BSCE 2 once you have them again in pharm. But they're just examples of ways you can change like constriction of vessels, dilation of vessels. That will shift the vascular function curve. And then you have the cardiac performance curve. So this is talking about mainly contractility more than anything. Like total peripheral resistance will affect both, because if the left heart has to pump against a higher resistance, it has to generate more pressure. So the actual like performance of the left ventricle will change as well. So biggest thing I think they could go for like guiding cross plots, again, is heart failure. They love heart failure because it's something that's actually pretty common in like the real world, more so than just like a run-of-the-mill like mitral regurg or something, which you're only going to see every so often. Heart failure can occur more often than not. So keep in mind with heart failure, the first change you would see is a decrease in contractility. So you would see that like graph or the lines that's curving out to the right shift down. So that's the first change. That is denoting heart failure is occurring. Heart failure is usually always compensated. The compensation means that you're increasing blood volume. So then the vascular function curve shifts up. So you would get to a point where cardiac output is kind of normal, but keep in mind that like if I had a high preload for too long, the left ventricle is going to have to deal with a lot of volume all the time, so it can get worn out. So it'll hypertrophy, and then that can result in decompensated heart failure, where now it doesn't matter that I've shifted the graph up. Contractility will dramatically decrease, the vascular function curve will shift down, and if the patient's not helped, like that's a really bad situation to be in. But biggest things to know is that heart failure, decrease in contractility at first, and that increased blood volume second. And that's second to the RAS system, which we'll talk about in a little bit. Alright, so pharmacokinetics and kinetics. Honestly, this is like 2 slides. I don't think it's really important for you guys. So equations, everyone wants to type out like literally all the equations they can think of with this section. I honestly think you should know like 3. Like the pH one doesn't count as an equation. The other 3 I think you should know. I think they're the only ones you need to know. Don't spend your time knowing anything else. Keep in mind with dosing rate. Dosing rate is just the fancy way of saying dose over interval. So if for some reason in the question they told you what the dose is, what the steady state is, and what the clearance is, you could still calculate the interval. So don't be afraid to like break the rate variable up into like dose over time. Steady state, keep in mind like that's going to occur after like 4 to 5 half-lives, and that clearance is talking about is it eliminated through the renal system or in the liver. Don't really need to know anything about clearance in itself. pH for this protonated and unprotonated form, something that's well absorbed in the stomach, so like weak acids are going to be absorbed when they're in their protonated form. So when they're on their, essentially they're absorbed when you're unionized or non-ionized. So for an acid, that means when it's attached to a proton, so HA is absorbed. With a weak base, it's going to be absorbed when it's in its unprotonated form, so when it's just the B form. Because when it's attached to a proton, it'll become B plus or BH plus, and then it's ionized. So ionized things are not absorbed. Non-ionized things are absorbed. So it's not necessarily like it's unprotonated is absorbed, as protonated is, or it isn't absorbed. Keep in mind, absorption is denoted by ionization. Half-life takes into account volume of distribution and clearance. So volume of distribution is saying like how much of the body volume the drug is spreading out across. So something that's like a small molecule that's very lipophilic that can cross membranes will have a very large volume of distribution because it can go everywhere. versus something that's large, like a large molecule that has like a positive or a negative charge, can't really move from the plasma. So small volume distribution for something that's large and ionized or charged rather, and that very, very large volume distribution for something that's small and very lipophilic. And then volume distribution can be calculated, so if you see this graph here, if you remember, like this is showing essentially like the rate of elimination of a certain drug, so it's distributed and then it's eliminated. So this is where you draw the straight line back to the y-axis, and you can find the concentration at time 0, which is that denominator value. I don't remember pharm being huge, just mentioning these 3 equations in case they show up. On the next slide, this was like a graph I gave to my DES kids back in the day. So this is just to say knowing when you're talking about affinity and knowing when you're talking about potency and efficacy. So the graph to the left, the y-axis can also be written as just percent of receptors bound. So this is drug concentration relative to how many receptors it's binding. So this is talking about affinity. From this graph, you can't talk about potency or efficacy at all. So if you're looking at the 2 lines, line A has a higher affinity, meaning that it binds more receptors at a lower drug concentration. And then the other graph is going to talk to you about efficacy. So it's talking about the concentration of drug and how much of the maximal effect it's achieving. So if I'm looking at like drug A, I can see it has a high potency, which means at a lower dose of drug, it's achieving an effect sooner. But it has a lower maximal efficacy than B. So B, it goes higher up on the y-axis, so it has a higher maximal efficacy, but it's not quite as potent. Spare receptors are huge. So the EC50 is less than KD50, which is saying that at a lower concentration of drug, I'm able to get 50% of the maximal effect, so the EC50, before I even bind half of the receptors, which is usually a good thing. Alright, so respiratory section. Really just thank all my friends for pictures later, but they're great. So respiration, I actually really liked respiratory stuff like after the fact. I remember I hated it going through like respiratory phys and stuff. Like cardio and respiratory physiology are huge. Like they're going to come back in pathology, you need to know them in and out. Some of the other physiology sections are a little bit lower yield, but these ones are really high yield. So equation wise, I would know this dead space equation at the top, the VD, VT, and then talking about carbon dioxide that's in the blood or versus expired. It can show up. They like these equation questions. I'm not just putting them in here to like put in pictures. I think you should know that. So with ventilation, also remember this is talking about tidal volume, so that's the quiet breathing volume, multiplied by respiratory rate. And then if I want to do alveolar ventilation, I'm taking out the dead space. So they can tie these two together where they could ask you to calculate dead space and then use that value to calculate alveolar ventilation down here. I don't think that'd be something necessarily I ask you on this exam, but it could be definitely something that shows up for your step later on. So lung zones, this is one of those like random things that I feel like shows up every so often. So keep in mind lung zones are based on gravity. So the way I usually think about it is like, remember like the alveolar pressure, so you have the alveoli unit that kind of, and around that sits the blood vessels. So if the pressure in the alveoli is very high, it's going to push against the blood vessels and essentially occlude them. So it makes sense to me that on zone 1, when I'm like standing up, and when the pressure of the alveoli is the highest one, it's going to push against the blood vessels, so flow is lower than it is compared to the base. Because at the base of the lungs, I see the P little a, so the pressure in the arterial system and the pressure in the venous system, aka the pressure in the blood vessel, is greater than it is in the alveoli. So the blood vessel is able to stay open and maintain flow. Keep in mind these are based on gravity. So this is when you're standing up, they form into zones. Your lung isn't like manufactured as zones in itself. So if you're lying down, essentially the flow becomes pretty equal everywhere. Even during like the lung physiology lectures, they talked about if you stand upside down, essentially the lungs zones flip from what you'd expect them to see. So keep in mind they're based on gravity. Also to the side of this picture, it talks about VQ ratios. So one of the things people sometimes forget is that zone 1, it has a lower ventilation, which means ventilation refers to the fact that I'm getting air into the alveoli, and perfusion refers to the fact of like blood flow. So at zone 1, it is lower for ventilation and it's lower for perfusion. But the fact is when you get to zone 3, perfusion increases so much, that denominator increases so much, that even though ventilation increases as well, the ratio goes down. So the ratio for VQ is highest at the zone 1 of the lungs at the top. but lowest at the bottom. But keep in mind that at the bottom, both values individually are greater than they were at the top. It's just that perfusion increases so much at the bottom, which is usually due to like when you're standing up, the lung zones allow for higher flow at the base of the lungs. All right, surfactant, this is something I mentioned yesterday. It ties in with like every subject really nicely, so it's really important. So it's made by type 2 pneumocytes. So in the picture on the right, you can see the type 2 pneumocytes, which are definitely the minority if you're looking at it like lung tissue, because type 1 pneumocytes make up like 95% of them. They're forming like the barriers and stuff, but type 2s are making the surfactant. Surfactant is the DPPC molecule, so that's the biochem. And then also the biochem, you're looking for sufficient levels of surfactant by looking at the ratio of lecithin to sphingomyelin. If it's 2 to 1, that's great. If it's less than 1.5, so that would be a concern for respiratory distress syndrome. Surfactant's function, so like kind of physiology, is reduce surface tension, because the lung unit in themselves, if it didn't have surfactant, would just collapse in. So surface tension is that force that's directed inward that's trying to pull the alveoli close. So surfactant reduces the surface tension so the alveoli can stay open. And then it starts to be made around the 24th week of gestation and sufficient around the 35th week. This little equation at the bottom is just talking about the relationship of tension, so like in this case surface tension to resistance and pressure, just to throw it out. Alright, spirometry and lung volumes. Spirometry is really important. Lung volumes is kind of like a random thing that they could show up, where they could ask you to maybe calculate lung volumes. But for purposes of here, like biggest things you should be able to separate out are obstructive and restrictive diseases. So obstructive, you would expect to see the FEV1, so the amount of air you can breathe out in 1 second. So usually, like if you could breathe 5 liters of air out, you should be able to breathe 4 of them out in the first second. So usually it's around like an 80% ratio. In this case, the FEV1 is low, the FVC is low, and the ratio is low. For emphysema, it's really the FEV1 that's dramatically decreased because these patients are losing their alveolar septa. So they have high compliance, like their lungs are able to receive air very well, but they're having the destruction of those elastic fibers. So when it goes for the elastic recoil to push lung air back out to expire, it doesn't have the same force. So that's why the FEV1 is dramatically decreased. FVC can be slightly decreased, or if it was about normal, don't like freak out if you show you that. It could be about normal. It's just the ratio will always be decreased. You can compare that against fibrosis. So fibrosis is something where there's like a collagen around all the alveoli. So now the alveoli can't expand very well to receive air. So that's why compliance is low, because the compliance is the change in volume over the change in pressure. So it doesn't stretch out very well anymore. The FEV1 FVC ratio is normal or slightly increased, because essentially with fibrosis, all of the lung volumes are short or smaller than they usually are, but they're pretty much like decreasing at equal rates. So the lungs are smaller, but the ratio between the lung volumes is about the same. So they really don't have trouble expiring. It's just the actual total volume is lower than it needs to be. And it can be slightly increased because now that you have all that collagen around the alveoli, they can kind of give it like an extra oomph when it goes to push out. You can collapse the alveoli a little bit more, so you can breathe out a little bit more air than you could before. In terms of like lung volumes themselves, for obstructive, so they're always thinking emphysema. For their example of obstructive, you have an increased total lung capacity, residual volume, and FRC. FRC being that point at which the lungs always want to collapse and the chest wall always wants to pop out. So at FRC, those are held in balance with each other. So it's increased in emphysema, and then it's decreased in fibrosis. So in this little flow rate diagram, it's showing you the x-axis is lung volume. So if you look at emphysema, you can see that it goes all the way out to almost at 6, which is saying that the total lung capacity is greater than it is compared to the normal. And if you look at kind of where the right part of that blue graph hits the x-axis, it's around 3. So the residual volume, so from that point all the way to 0 is residual volume, is greater. So this is what the graph is showing you. It's also showing you the flow rate is not what it's supposed to be. So that makes sense for emphysema. Expiration is much decreased compared to normal. Fibrosis, you can see that it's shifted to the right, so the lung volumes are smaller, but you see that kind of the same ratio, or the same curve that you see normally. So the flow rate is pretty normal, like I said, the FEV1 FVC ratio is about normal, but the lung volumes in themselves are smaller. Alright, so the next picture is something I drew for my DES kids last term. I know Marisa used it. If you guys went to her DES last term as well, I was proud of myself for making it. So this is essentially to talk about VQ mismatches. So again, there's problems where ventilation can't occur very well. So something like bronchitis or pneumonia are essentially saying there's problems where the air has trouble getting into the alveoli. So like with bronchitis, it makes sense because you have all the mucus that's in the airways and inflammation that's occurring. So you can't really get the air into the alveoli. So ventilation is impaired. Perfusion for pretty much every single case besides a pulmonary embolism is normal. Keep in mind with pulmonary embolism, perfusion is like completely knocked out. So this is like one extreme where VQ can be infinity because there's no perfusion occurring. Even though the lung unit is able to fill with air, so ventilation is fine, there's no perfusion, so V over Q is infinity. So sometimes they compare this to anatomical dead space. So dead space being where something is ventilated but not perfused. So the example of anatomical dead space is like your trachea. So your trachea doesn't function in gas exchange, but it is technically ventilated. Like air does go past your trachea, but there's no gas exchange. So essentially it's ventilated but not perfused. And then the other extreme would be pulmonary edema. So in that case, you have fluid that's filling the lung unit. It usually occurs as a result of heart failure. So this kind of goes to tie in with Starling forces. So like push and pull forces, hydrostatic pressures, oncotic pressures. So usually what changes is hydrostatic pressure. So like in heart failure, keep in mind that the left part of the heart is receiving blood from the lungs, or like that's the step that comes right before it. So if the left heart isn't working very well, all the blood is going to back up into the lungs. So essentially those blood vessels around the alveoli will increase in hydrostatic pressure. So there would be a greater drive for filtration. So one of the things that can filter is fluid into the lung unit. So you can get pulmonary edema where you have fluid that's filling the alveoli. So even when you go to ventilate, the oxygen can't get to the diffusion membrane. So ventilation is 0. And then perfusion is normal, so the VQ ratio is 0. So kind of one extreme to the other. Emphysema and fibrosis talk about diffusion impairment. So diffusion being that like I could fill the alveoli pretty well, but when I go to put the oxygen from the alveoli into the blood supply, in the case of emphysema, I have less surface area to do that, so diffusion is impaired. And for fibrosis, I have a greater barrier for diffusion because all that collagen sits between the alveoli and the blood supply. So diffusion is also impaired in that case. And then for the others, we just call them VQ mismatches. Actually going to the next slide, talking about shunt flow. So ignore like all the variables for this. This was something I drew out for someone last term from a moto question. But like the idea here with a shunt is that shunts refer to blood that's going somewhere else, or it's not being ventilated at all. So like in this picture, if you're looking at the circuit, so the top part is saying there's blood that's going to the lungs, and then you can see all the little alveoli that are going to put oxygen into the blood supply. So under normal circumstances, you can measure venous blood that sits in the pulmonary artery. So don't forget, arteries go away from the heart always. But the pulmonary artery is a little bit unique because it always carries deoxygenated blood. So it's going from the right heart, so the venous blood, to the lungs to be oxygenated, even though it's an artery. So you can measure what the concentration of oxygen is there. You can measure what the concentration of oxygen is like the capillary level, and then you can measure it after it kind of pools back together. So under normal circumstances, there shouldn't really be shunt flow occurring. There usually can be like a 3 to 5%, so that's just to say some blood can go back to the heart and perfuse it. But normally the CO2, so essentially the oxygen that's like being ventilated in the capillaries and the lungs, should be about the same content of oxygen that's coming like pooling back together. Like they should be the same stream. So if those are very different, that would indicate to me there's shunt flow occurring. So like the bottom little strand is saying that there's some blood that's going somewhere else. So it's a shunt because it's not being ventilated at all. And one of the things they like to go over physiology is that if you hook this patient up to 100% O2, it doesn't help them. That's because this blood isn't being ventilated. So even if I gave the best oxygen possible, it doesn't matter because they'll never kind of see that. They're going somewhere else. So one of the examples of like a shunt flow that they use is like a right to left shunt of the heart. So you essentially have blood that's not going to go to the lungs at all. So those are things like, the tetralogy of Fallot, the transmission of the great vessels, all those T things, where the blood is shunted away, it's not being ventilated, so it'll never get oxygen put into it, which will decrease the total amount of oxygen in the systemic blood. So shunt flow, keep in mind what's going on there. If you need more of an explanation, let me know and I can say later. Next problem are differences in oxygen content. So I emphasize like the normal arterial oxygen at the top because this is something people sometimes get tripped up on, especially for carbon monoxide poisoning. We were just talking to term 1 about it, and I mean it's the same every turn. They always give you the question of like, what happens to carbon monoxide poisoning, and the answer is that arterial oxygen is normal, and no one wants to pick that because that sounds so like obscure. Like, how is it that this condition where I'm breathing in carbon monoxide and essentially like dying from that have normal arterial oxygen? So that P little AO2 is a measure of oxygen diffusing into the blood, or dissolving into the blood rather. So in carbon monoxide poisoning, there's no problem diffusing oxygen into the blood. It's just that once the oxygen gets into the blood, it also has the carbon monoxide that diffuses as well. So when the hemoglobin goes by, it binds carbon monoxide and not oxygen. But the arterial oxygen is normal. It just doesn't get bound. So it's a low oxygen content because the saturation of oxygen is low. In a question stem, they might say the pulse ox is normal. This could be, like, again, a pathology question or a physiology question. So I'm mentioning it here in case they use it as a physiology question. So the equation at the bottom talks about oxygen content. I don't think they'll ever ask you to calculate oxygen content. It's really just important to know what goes into it. So you need to know hemoglobin levels, you need to know saturation of oxygen, and then P little AO2. So not all of those have to change oxygen content. In the case of carbon monoxide poisoning, the saturation of oxygen is low, and that decreases oxygen content. So keep in mind the saturation of oxygen refers to the fact that did hemoglobin pick up O2 or not. In this case, it didn't pick up O2, it picked up carbon monoxide. So the saturation with O2 is very low. Even though it might look deceiving on a pulse ox, which essentially just can read the carbon monoxide as everything is fine, even though it's not. Anemia would be an example where the hemoglobin level part of the oxygen content equation is affected. So it's not the problem that the hemoglobin that is there can be saturated. It's saturated just fine. And oxygen is dissolving to the blood just fine. So arterial O2 is okay. But with anemia, you have low oxygen content because hemoglobin levels are low. Always make that connection with anemia that hemoglobin is low, and that's what the problem is. Polycythemia is like the flip side of that, where you have oxygen content is high. So this is why like athletes will go and train places like high altitude. So when you're at high altitude, your body will release erythropoietin, which makes more red blood cells. It's released by the kidneys. So if I'm making more red blood cells, I have more hemoglobin that's in those red blood cells, so I can pick up more oxygen. So that's really helpful for athletes, even though, like, you know, the jury's out on it. Is that cheating? Is that not cheating? That will have a higher RBC content because now they have the ability to pick up more oxygen to feed their muscles, which is great. Like if there's someone, you know, that's like a cyclist or something that has to use their muscles for like long periods of time, they can receive oxygen to the tissues very well because they have a high oxygen content. All right, so next slide, hyperventilation, hypoventilation. Biggest thing to know is that AA gradient is normal. So for BQ mismatches and like shunts and everything we've talked about kind of up till this point, AA gradient might be skewed. Besides like carbon monoxide poisoning, things like that, because P little AO2 is okay. But BQ mismatches and shunts, AA gradient is thrown off. Hypoventilation, AA gradient is normal. So the difference between the oxygen that's in the alveoli and the oxygen that's in the arterial blood. So hypoventilation in the question stem, they would give you like someone that overdosed on narcotics that directly suppresses the respiratory center. You might have talked about that in neuro for like a minute if you, they brought it up. In that case, both values are low just because you're not ventilating at a rate that you need to ventilate anymore. So you can get a decreased pH because essentially you're retaining carbon dioxide. It need to be for like a long period, so you can get like a respiratory acidosis. And hyperventilation, the example they usually use is high altitude. So high altitude, essentially like the quality of the air has changed to where like the pressure is different from what it used to be. So when you take out the fractional oxygen content, it's lower than normal. So you're going to try to breathe more frequently to get the oxygen you need. But kind of as a trade-off to that is that if you breathe too frequently, you're going to blow off a ton of carbon dioxide. So you can get a respiratory alkalosis. So again, for both of these, AA gradient is normal. They could use these, though, as the tie-in with metabolic acid-base disorders. And then the mention at the bottom for peripheral and central chemoreceptors, know what they respond to, and know where they're located, like the carotid aortic bodies or in the brain. Right. So renal system, last big one, just a couple mentions of embryo. I think just pulled out a couple things. So the horseshoe kidney is really random, but we even had like a path slide that was like completely devoted to it. So horseshoe kidney, essentially the kidneys don't split apart, so it's like one big kidney. So when it goes to ascend, it gets caught on the inferior mesenteric artery. about as much as you need to know about it. It's associated with like Down syndrome. And then oligohydramnios, we talked about this last night, but I'm mentioning it in renal too, because keep in mind that like when the baby is sitting in the amniotic fluid in utero, the amniotic fluid is essentially like their urine. So if something was wrong with the baby's kidneys while it's developing, it's going to get oligohydramnios because it's not able to urinate. So the fluid that's in the amniotic fluid would be low, so you get oligohydramnios. So the problem with that would be like pulmonary hypoplasia, like we mentioned last night. Or you could also get limb deformities. So essentially they get pushed against the sides of the sac in the mom. So they can get limb deformities. It's called like Potter sequence. You don't need to know that for now. But that would be a problem if there was like a dysfunction of their kidneys. So they're not able to urinate to make the amniotic fluid anymore. Equations you need to know. Again, this is equation heavy. They could ask you to calculate like different volumes of body water. I feel like that is probably lower yield, but I'm just mentioning it. Clearance, I think, is actually really high yield, because what they'll do is they'll give you like a bunch of lab values, like all these different values of things in the serum and all these different values of things in the urine, and they'll ask you to calculate GFR. So GFR, you should keep in mind, is calculated by creatinine clearance. Ideally, it could be inulin clearance, but pretty much like 95% of the time they're going to ask you to use creatinine values. So creatinine can be used because it's freely filtered and it's not really reabsorbed or secreted. It's a little bit secreted, but for the most part, it's going to tell you exactly how much of something was filtered across. So that's why it's a good marker for GFR, because it's filtered, not reabsorbed, and only like a little bit secreted. So it can overestimate GFR, but for the most part, you'll always use it to calculate GFR. So the UX is the concentration in the urine times V, which is the urine flow rate or urine volume, and then PX is the concentration in the plasma. And while creatinine can be used to calculate GFR, PAH, the like para-aminohippuric acid or whatever it is, can be used to calculate renal plasma flow, because this guy is freely filtered and 100% secreted. So you pretty much are just shoving everything that was in the blood. Like if it's not filtered, it will be secreted later. So it's a great marker for plasma blood flow. So pH for RPF and creatinine for GFR. They could ask you like to put these two concepts together to calculate filtration fraction. So essentially, if they wanted to like make this a really long question for you guys and ask you to calculate filtration fraction, you would calculate creatinine clearance for GFR, and then you would calculate pH clearance for RPF, and you can divide the two together to find filtration fraction. This is a picture from first aid to just kind of show you the unit in itself. It kind of points out the Starling forces as well, but usually people understand those pretty okay. So I won't waste your time like talking about them anymore. They're just like the push and pull forces. If you have questions about them, let me know after. The next slide, I know Nick and Ben showed it yesterday. I don't really want to go over it. Just keep in mind like if you constrict like the efferent, you're going to allow GFR to increase. If you constrict the afferent, you're decreasing GFR. So one of the things that you should know, though, that we'll talk about in a second, is that angiotensin II, when it's released, is going to preferentially constrict the efferent arteriole, which might sound counterintuitive because usually angiotensin II is released when there's like low volume states. So essentially what it's trying to do is to hold the volume in your body because you don't have like a lot of it floating around. So it might seem weird that you would increase GFR, but essentially angiotensin II works to like kind of restore body volume to where it needs to be, but it doesn't do it at the expense of the kidneys. So it constricts the efferent so the kidneys are still perfused. So when you're in low volume states, you don't want to completely like not perfuse your kidneys at all, because they'll become ischemic and like you'll go into renal failure. So you don't want that. So the angiotensin II works to kind of restore the volume in the body, to hold everything in place, make sure the heart's getting enough volume that it needs. But it allows for perfusion of the kidneys to occur, so the kidneys aren't like failing in the process. We'll talk about that in a slide or two, but knowing that angiotensin II constricts the efferent I think is useful. The next slide, I don't know why like they like going after it, but the flow of like blood, like which arteries it's going to, like the order of them, it can be asked. So I'm mentioning it here. I wouldn't like try to break your brain over this. It's literally just mentioning it if you have like extra time, because we all always have that. You can memorize this too, but they like this flow of which artery is going to where. And then the next one, just putting in like a blank diagram because like you'll expect to see this, where they can ask you a million questions about this. They could ask you like one of the big ones they like to ask is where's the triple cotransporter located? In this case, you need to know it's in the thick ascending limb. So if you're looking at this diagram, little g would be where the triple cotransporter is located. Knowing the different parts of the nephron is big. They could ask you like where the sodium chloride transporter is. So that's in the distal convoluted tubule, so that's like little choice D. And then besides that, they could ask you like where things are impermeable to water, where they're permeable to water. But just be familiar with this diagram. Like if for some reason you're not like 100% sure on which part each letter is pointing to, like just look at that later. I would expect to see like a blank one like that. The next one is like, I hate this graph, but for some reason they like asking about it. The biggest things I think to know is this is talking about, is something at higher concentration in the tubule or is it more in the blood? So the way I can kind of remember how to orient myself is that I know that pH is always the top line because this is a measure of renal plasma flow. So this is something that's freely filtered, so I'm putting as much of it in the tubule as I can up front, and anything that I didn't put in the tubule initially gets put in later, it gets secreted in. So that's why it's always the top line. So it'll always be the highest concentration in the tubule because it's, again, freely filtered, 100% secreted. And then creatinine's a close second. See that creatinine and inulin are kind of right next to each other because they're calculators of GFR. So just if you're looking at the picture, pH is always the top line, and then creatinine and inulin always kind of go together. So I think those are the important lines you need to keep track of. And then besides that, like if you're looking at the very opposite end of the graph, like glucose and amino acids, what you should take from this is that these are pretty much fully reabsorbed in the PCT. Like glucose is like 100%, I think, and then amino acids are like 98%. So one of the tie-ins with this is talking about diabetics. So diabetics essentially exceed the renal threshold for glucose. So glucose should be 100% reabsorbed always. But if you have so much glucose all the time, those transporters can get saturated. Nikki and Ben talked about this yesterday. It's kind of like a genetic heterogeneity, I think is the fancy term they use for it. But essentially the transporters get saturated to where they can't reabsorb the glucose anymore. So some of it starts to end up in the urine just because you're fully saturated and you're not reabsorbing everything you can reabsorb. Alright, the next picture is just the RAS system. I don't want to talk through like each of these things, so I don't want to read to you because you guys can read for yourselves. Just like basic things, know that renin is the first thing produced. So RAS is the tubuloglomerular feedback. So you have autoregulation systems in the body. The one you should know first is the myogenic response. So that doesn't have to do with this. So myogenic response refers to the fact that if there's more blood flowing through a vessel, the vessel is going to stretch out. And one of the things it does initially in response to that stretch is constrict. So myogenic response refers to the fact that mainly like arterioles got stretched out so they contract back in. And the reason that's important is like in cases like exercise where blood flow is increased dramatically. Like exercise, I mean like looking at like the guiding cross pulse and stuff, it's kind of amazing because you're increasing cardiac output, you're increasing contractility, you're increasing like blood volume, like everything's kind of like going nuts on like those graphs. But you have increased blood flow throughout your body, which is great because your your skeletal muscles need that, and your heart needs to pump more. But when you look at like the delicate vessels in like your cerebellum and your brain or in your renal system, you don't want them to experience like rapid changes in blood flow because that can like burst all of those arteries. So the myogenic response is in function because after blood flow increases, that constriction holds the flow to be pretty constant, which is really, really important with cerebral circulation and renal circulation. So that if they gave you the example for exercise and they say how would flow change in the following organs after autoregulation has occurred, aka after the myogenic response has occurred or something like that, keep in mind that cerebral circulation, you would want to hold flow pretty constant because you want the myogenic response to hold those vessels constricted a little bit so they're not bursting in result to the high cardiac output. But you'd have high flow through the cardiac system and you'd have high flow to skeletal muscles because that makes sense. You need increased blood amounts to your muscles. So that's myogenic response, and the other arm of autoregulation is tubuloglomerular feedback, which has to do with this. So essentially your maculodental cells will sense sodium, and it makes inferences about how much volume of fluid is in the body based on how much sodium is there. So if sodium is low, it's going to release renin. So renin goes to make angiotensin 1. Angiotensin 1 will make, or angiotensinogen, which makes angiotensin 1, which makes angiotensin 2. So angiotensin 2 is the one that actually does stuff. So angiotensin 2 will constrict the blood vessels, like we said, it constricts the efferent arteriole. It also will stimulate the release of ADH because your thirst centers are stimulated. So ADH, again, is from the posterior pituitary. It sits there, but it's actually made in the hypothalamus. It reabsorbs water. And then I just put like my own little like sodium excretion next to ANP and sodium reabsorption next to aldosterone because you can kind of think of them as opposites of each other. So ANP is like the atrial natriuretic peptide, so it's released like in the ventricles. So essentially it's your heart realizing that it's being stretched more than usual. So this is released to excrete more sodium to kind of tone down body volume. So ANP again released from the atria and the ventricles in the heart in response to that increased stretch to excrete sodium because I use sodium to move water. So if I'm excreting sodium, that means I'm losing water. So essentially what you're trying to do is you're trying to decrease total body volume, which even if you looked on like the Guyton cross plot, you would shift the vascular function curve as a result of that. So that's how those concepts can tie together. Aldosterone is reabsorbing sodium, so you would try to be increasing body volume. All right, so next slide. So this Davenport diagram, these are just two pictures of the same thing. Just putting it in here to mention it, like look it over. I think it's important to know. Like know if you're shifting up or down. If that's talking about like metabolic changes left and right, usually talking about respiratory changes. So look at this graph a few times. I would expect to see maybe a question or two on it. All right, GI we already did, so we're going to skip those. Endocrine we already did, reproduction I already did, and then actually we're going through this much faster, I think, than I thought we would, which is good. So random pictures, I think there's only a couple in here. I'll put more up if I can think of any more. I've kind of made this like PowerPoint on the fly, so I can't include like literally everything. I mean, there's a 700 whatever page book of first aid that's dedicated to everything you're supposed to know about the step. So this is really just trying to point out things that are like more important than others. So MSK in itself, like that module is high yield for like fractures and breaks and like brachial plexus tears, like nerve injuries. Muscle physiology, no one cares about it. Like besides the physiology department, you won't see it in Firecracker, you won't see it in first aid, no one cares. Like they'll never talk about like muscle preload ever, like skeletal muscle preload. The only thing they do care about, oddly enough, is like this little stupid EM picture of all these different lines, which is I know is a pain. Things you should take from this is that these are essentially trying to separate thin filaments from thick filaments. Thin filaments are those like lighter colored areas in the I band. So I band is talking about an area where there's only thin filaments, and thin filaments are made of actin. So this is an actin-heavy area. And in the middle, the darker area, so if you're looking, I made my own little thing because I forgot the H zone. So the H zone is where there's only thick filaments. So thick filaments, think myosin. So they like this picture, and they also like talking about like the contraction cycle. So keeping in mind that myosin and actin will attach to each other, and that ATP is what's used to detach them. So when ATP is there, it's going to be hydrolyzed, so actin and myosin can detach from each other and get ready to do the power stroke. So in cases like rigor mortis, when you don't have any more ATP being produced, essentially what happens is that the myosin and actin can't dissociate. So all the muscles are in that contracted form always, and they can never relax. So rigor mortis, myosin and actin can't dissociate from each other. This picture, no, more than anything, the A-band doesn't change. So the A-band is kind of just like a set region in itself. All the other ones will get smaller when the muscle contracts. And keep in mind that Z-disc to Z-disc is the sarcomere unit. So that's the actual, like, where that will get smaller and bigger with contraction and relaxation. The next picture is what I mentioned yesterday. Like, I couldn't find a great picture that I loved, but this is just to mention to you that those EM images of like the cell and all its organelles can come back. It's really annoying. And sometimes to me, like depending on how good the picture is, the Goldie sometimes looks like the ER, but like they'll use this as like a third order biochem question or whatever, where they'll ask you like, hey, this process is occurring, like where is it occurring in this picture? And you need to know if it's in the cytoplasm, if it's in the mitochondria, if it's something that's acting at like nucleus level. So with those like rate limiting enzymes we talked about yesterday, if you have extra time, it'd be useful to know like where these processes are occurring. More than anything, know that like gluconeogenesis is occurring like in mitochondria. Know what's really really important, like location wise, is ketogenesis occurs in the liver mitochondria, and that ketone bodies are made in the liver, but they're not used in the liver. So remind yourselves that the liver doesn't have that, like thiophorase is like the shorthand version of the enzyme, and then there's like a super long name. I think it's like succinyl-CoA acetyltransferase. There's some super long name for the enzyme that utilizes ketone bodies. So double check that. I know thiophorase is the small version of saying the word, but it's only present in peripheral tissues. So only peripheral tissues can use ketone bodies, but only the liver makes ketone bodies. All right, and then other pictures, knowing what these cells look like on blood smears. So I think this would be a histo tie-in. Someone was asking about histo earlier, and like if it can show up, and I'd say yeah. Like there won't be like a ton of explicit histo questions, but like things like this with the neutrophils, macrophages, whatever, they could give you like, oh, someone has like acute inflammation or whatever, like you would see a bunch of neutrophils. Knowing like what the eosinophils contain, they have the major basic protein, things like that. Basophils and mast cells, they have all the histamine in them. And that lymphocytes, you'll talk about when you get to like immunology, will differentiate further. Plasma cells are mature B cells. And that monocytes are kind of those precursors to macrophages. And macrophages are monocytes when they get to tissues are macrophages. So you have like Kupffer cells in the liver, you have the microglia in the neuronal system, you have like dust cells in the lungs. Macrophages are like many different places to do what they need to do. And I think the last picture I had was, I couldn't find a great one, but like they really like knee MRIs. Like this is again is the MSK module. Like if you had an ACL tear or an PCL tear, they might show you an MRI image. There was like a good one in UWorld, but like I was having trouble finding the picture earlier today of like the PCL. It was like the posterior view of the leg, and it was like kind of like a little curve. Like a dark little curve was the PCL if you're looking at the back of the leg. I know it's super random, but there's like little things that can show up. Besides that, that was kind of quicker than I expected, but I'm sure like no one's complaining because it's everyone's bedtime now. If you guys have questions, let me know. Please, more than anything, don't stress too much about this exam. Yes?
Do you mind like drawing back a little one for like the...
Oh, yeah. So we have actually brought a marker. So I can't believe like some people have gotten this far and didn't know it. It's because like I'm an idiot and don't remember this rule ever. So this is talking about the adrenal glands and the different enzyme deficiencies. So you're making two columns for hypertension and subsidiary sex characteristics. And what you do is you write out the different numbers. So I don't remember if they're like hydroxylase enzymes or whatever. I just know the numbers. So every time I see a 1, I'm making an up arrow. And the way to use this is that in a question stem, it's going to give you like a presentation of something. So I got a kid that had like high blood pressure, so he's hypertensive, and he had like increased uralization, which is a fancy word for increased secondary sex characteristics. And it would be 11 whatever hydroxylase whatever enzyme deficiency. Or if they came in and they had normal blood pressure but uralization, I would expect to see 21. So every time you see that up arrow, it's increased in that column. So this would have both of these symptoms. This guy would only have the hypertension, and this guy would only have the increase in sex characteristics. If anyone hasn't seen that, life changer. I know I need to memorize that chart eventually, but today is not the day. But yeah, that'll pretty much get you an answer most of the time.
Is that the first day?
No, it's on the DL. Like honestly, for my term 1. Like the day before the exam, my histo girl showed me that. I was just like, oh my gosh. So I think it's great. Between that and Mr. Atkins are best mnemonic things ever. If you guys have any other questions, I'm free to hang out for a little bit. If not, I'll post this later. But yeah, you guys are gonna be fine. So don't freak out. Like if you do have questions, like feel free to ask me the next few days. But it's not gonna be a bad exam, I promise. Yeah. Welcome. You're welcome.